Start with Karen, really. Just want to give a quick update on the AGM and the elections which happened recently.
Yes, thank you very much, Nadeem. And colleagues, you may have already heard, but we've just completed, if just move on to the next slide, Steph. We've just completed the process. Oh, it's the wrong slide, actually. If you go back to the previous one, I'll talk without it, it's the wrong one. We've just completed the process for electing the clinical director representatives on the NHC board, and the three candidates that were elected were Dr. Saidor Rahman, Dr. Rupon Chatterjee and Dr. Anil Shah. And so they'll join the recently elected members from the practice directors, which was Dr. Nadine Farouk, Dr. Arpana Patel and Dr. Claire Davidson, whose names hopefully are all familiar to you because they've been on the board for the previous term. So it's a returning 6, which hopefully is a positive in terms of continuity. And the board will be determining the chair of the board at their meeting next week. So the process we go through is obviously to elect the members, and then when the members meet, they determine the chairman of the board, and we'll let you know the outcome of that after Tuesday. But also to say, if we just move on, Steph, we've got a really short little video which might be slightly fun, we hope, to entice you to come to our annual general meeting, which is on Thursday next week. And I don't know if Steph can get it playing.
I'm having a few technical issues.
I don't know where
the video has gone.
So whilst Steph's resolving the technology to get the video playing, it really is only 30 seconds. I can say, so a couple of things. One, we're at Stratford Town Hall from 6 o'clock. Parking, if you need to, is available and we will reimburse you. We will also provide you with hopefully a lovely supper. And it is a great opportunity, I think, to make sure that the Federation is doing what you want it to do, hold us to account for all the things that we've delivered and say, did we do them well enough, etc. But also give us a real strong view of what you think we should be doing going forward. So our board members will be there, and there will be an opportunity over a supper to have a good discussion about the next steps for the Federation. And hopefully Steph has got the video to play.
Thanks for that,
really short taster, and we will be distributing the annual reports both digitally, and we've got a limited number of printed copies so that every practice can have a printed copy as well. But we'd really love to see you at the AGM on Thursday.
Yeah, thanks for that, Karen. So yeah, next Thursday, Stratford Town Hall, 3-course Asian meal, and yeah, look forward to seeing everyone, and we'll be sending out invites again over the weekend or early next week. We move on. Dr. Rachel Parker, who will be talking to us about the Community Pharmacy Air Quality and Asthma Project. Hi, Rachel.
Hello, everybody. Is it all right if I share the slides? I find it a bit easier to present myself. Is that okay?
That's fine.
Thank you. So hi everyone, my name's Rachel. I'm a GP in Tower Hamlets, and I'm the North East London clinical lead for air quality. So I'm just going to talk to you about a project that's been developed. At the moment it's due to launch next week with community pharmacy in Newham. So the background to this is I've been working in air quality since about 2019. So we started with a project in Tower Hamlets that was to do with air quality and asthma. And it was part of a larger kind of QI project to improve asthma care. And we thought that as part of that, we needed a section on air pollution and air quality. So during this project, we co-designed some resources and we provided some training and engagement with primary care mainly to empower clinicians to talk about air pollution with their patients. And the co-designed resource was created with sort of key stakeholders, including children and families in Tower Hamlets and North East London. And I'll show that to you in a moment. Subsequently, we then rolled, because of the successes of the programme in Tower Hamlets, we rolled it out North East London wide, and we got funding for my role to be the air quality clinical lead for a couple of years. And we've been embedding those resources throughout North East London, so they should be accessible to everybody through EMIS and through sort of local platforms. And we provided some comms and training, again, a sort of training package to practices throughout North East London. As part of this, we've developed 2 different projects that we've been working on to try to make our resources as accessible as possible and actually to be used throughout North East London. One of those is to take the resource that we created and actually animate it. So we've animated it now and we've got it available in about 6 or 7 languages currently, but we're just getting the voiceovers done in total 13 different community languages. So that's just, it's a 1.5 minute long video. And it just takes you through the key kind of actions that you can take to avoid exposure to air pollution, just to make it as accessible as possible to all of our communities in North East London. And then this community pharmacy project is sort of an additional project that we're trying to push forwards. So this is the resource, the kind of main key resource that we put together, which is this air pollution and new leaflet, which has these 5 key actions that were agreed on the front page. And these are things that we hope, one, if not all of them, will be something that most of our patients will be able to do, and they can choose to take those actions every day if they're able to, or just on high air pollution days. So that's the resource that we've got and we've embedded everywhere. Just briefly, why do Newham residents in particular need to know about air pollution? Well, sadly, in North East London, we've got the highest number of deaths related to air pollution in the UK. And in 2019, in Newham, 77% of deaths were due to air pollution. And this is from the Mayor of London. In 2019, all of the local authorities in England were ranked according to the proportion of deaths attributable to PM2.5, which is particulate matter air pollution. And 7 of the top 10 of these are in North East London, and right at the top there, you can see Newham. And this is another study that was done by the British Heart Foundation using ONS data from 2018, again, looking at PM2.5 limits. The WHO limit for PM2.5 is 10, and Newham's is 13. And you can see it there again, right at the top of the list in terms of poor air quality, basically, for Newham. So it's a big problem in particular in Newham. And we know that air pollution affects all of us right from the moment that we're born until we die, but it's especially dangerous for children with asthma. And also, again, a key point to really consider is that we know it disproportionately affects minoritized, ethnic and socially deprived communities. And so it's a big health inequalities issue. And if you look specifically at asthma in Newham, so this is looking at all of the kind of North East London boroughs, Newham's sort of 4th down the list there. You can see that in the numbers of asthma sufferers, so this is children who are prescribed an inhaler, the numbers are high, but in addition to that, in Newham, you have a higher proportion of very high risk or high risk asthma patients. So looking at these 2 things combined, we identified that Newham was specifically an area of high need that really needed this work, as an area that's worst affected by air pollution and has the highest caseload of high-risk asthma patients. So what we're asking community pharmacies to do is to have quality conversations with children and their families around asthma care, but specifically around the impacts of air pollution on their health, and then what simple steps they can take to reduce their exposure. And what we're trying to do is to improve their understanding of the impacts of air pollution on their asthma, how to mitigate those risks, but also more generally to improve their asthma care, to reduce their reliever inhaler overuse, and to look at the wider picture, because it's obviously linked in with a much bigger conversation to do with the carbon footprint of inhaler devices and overprescribing. So thinking about reducing that primary care carbon footprint. So these are the 6 GP surgeries that we've identified in Newham, which have the highest caseload of high-risk asthma patients. And what we've done is we've recruited 19 community pharmacies, which are local to these 6 GP practices. We're asking them to complete a short training webinar, which is pre-recorded, and then a short video, so that the bulk of the funding that we've got for this project has come from DEFRA, and they themselves have also developed a web tool which can be used by patients and families to learn a bit more about air quality and think more specifically about the air quality in their own area. And so they've produced a short video on how to use the web tool, and we're asking the community pharmacists to share that tool as well. In terms of recruiting patients into the service, this is going to be done in 2 ways. So opportunistically, when their patients are coming in and collecting the asthma medications, but also those 6 GP surgeries that I showed you before, we're developing a local services button in EMIS, so that the referrals can come directly from primary care out to those community pharmacies as well. And this is the referral button. If you've not seen it before, it's the same button that you would use to refer to CPCS. So in terms of who we're actually recruiting into the project, so it's any children under the age of 18 who are prescribed an inhaler. Importantly, they don't need to have a formal diagnosis of asthma. They just need to be on any inhaler, and they need to be registered with a Newham GP, and then they need to fulfill at least one of the following criteria. And these are criteria which make them automatically higher risk in terms of their asthma patients. So any children under 8, anybody prescribed more than 3 SABA inhalers in the last year, 2 or more courses of steroids, and then you can see the rest there. I think it's interesting to see we've also included anybody who's just prescribed a SABA, which is another kind of high risk category. And sadly, we are seeing some patients who are using their own nebulizers at home. So again, another high risk factor. And we're just excluding adults and anybody who's not registered in Newham. What we're actually asking the pharmacists to do, we've given them this checklist basically of what to complete after they've attended the training webinar. So the first 2 points are on air pollution. So one is using our resource to talk about air pollution, both indoor and outdoor, how it impacts their health and how to reduce their exposure. And then there's a website. Our website is on the resource with a QR code, and that goes to the website where we have all of those videos in all the different languages. So if they want to watch it as an animation as opposed to reading the leaflet and want to watch it in their own language, then it's all there. And then, as I said, DEFRA have developed a web tool as well, which they'll be sharing. We're specifically asking the pharmacists to check with the patients. They're using that as an opportunistic time when they have their own inhalers with them, and hopefully their own spacers, to actually check inhaler technique with them, but we're also providing them with placebo devices to do that. And we're asking them to talk more broadly around what the difference is between their inhalers, preventer versus reliever, how they should be using both, why it's really important for them to have an asthma annual review. And then briefly at the end, just talking a bit about green prescribing, the carbon footprint related to inhalers, and just identifying patients that might be eligible for the MART regime and asking the families to then go back and discuss that at their next annual asthma review. So this is then later down the line. So once they've had these conversations, they'll be entering the data into this database called Farm Outcomes, and there will be some communication that will come back to the practices that the patients are registered with. So you can see I've just put the sort of last page of the database here. So you just look at the consultation outcomes, and this will be the bits that are communicated back to the GP. We're conscious that we don't want to have long letters that are very wordy with lots of information, but just some key points that might come out of that conversation. So firstly, that the patient might be suitable for the MART regime, and that conversation has started with the patient and family. That their inhaler technique was reviewed and corrected. We have given them the opportunity to put a little bit of free text if they want to, and then just talking about ICS adherence, whether it's poor or whether it's good and has been reinforced. And just as a last point, there might be urgent actions taken, obviously, if the patient is unwell, and that will go back to the practice as well. So the service is due to launch next week, and it will run from October through to March of next year. with a bit of time at the end to then go sort of analyse what we've done and kind of measure the successes of the project. There's a potential for us to get further funding, hopefully to do a more robust evaluation, and this is a pilot really that we're piloting in Newham for the reasons outlined, but we would hope that in the future it's something that we might even be able to roll out throughout North East London if it's found to be something that's helpful. And that's it from me. Any questions from anybody?
Thanks, Rachel. Yeah, so 7%, quite high really, and the PM number seems quite high, so obviously a big problem locally with air pollution. So I suppose, have you spoken to the pharmacists and the practices in these practices?
So the pharmacists have been recruited now. There are 19 of them. Comms are going to go out to the GP practices. It should be today, just to make them aware of the project. And then for the team from the LPC, who we've been working really close with, so that's the local pharmacy committee, we've been working really closely with them. They will actually come out to the practices or offer to come out to the practices.
So you've recruited community pharmacists or in the practice?
So the community pharmacies are the ones who we've recruited because they are the ones who are actually going to be doing all of the work. They're the ones who are going to be kind of providing the service.
But if we need practices to refer into air using that button, do we need the local pharmacists to be aware or have some training or link?
Sorry, I don't understand the question. Which local pharmacists?
Sorry, our practice pharmacists, I meant, sorry.
Practice pharmacist, okay. So the idea of the referral pathway is that from general practice back outwards is that it doesn't need to be done by a pharmacist. It could be done by reception. There are just those key inclusion criteria, and if the patient wants to go to this service, then they can be referred just like you would for CPCS, or if they're seen by a GP and you think they might be eligible, then you can use that. So it doesn't necessarily need to be the pharmacist, but the LPC, the team at the LPC will be coming out to the practice during the first couple of weeks of the project to offer training a little bit more on, you know, what the service is and how to refer into it. So there will be some training provided there. We won't be asking that the GP practices themselves partake of the hour-long kind of training webinar that we've put together, because that's really for the pharmacists themselves who are then providing the service. It's more for the surgeries to understand what the benefit of the service is, who is eligible, and who they can refer on.
Okay.
Thank you, Rachel. I think Rachel came to our trainers meeting first, and then she presented, and that is the reason we liked her to come here. Bare minimum practice can do switch to green inhaler, and I think, Rachel, there are posters available for the patient education for the green inhaler.
There are lots of resources that we're going to share. So again, the 6 practices who so the referral pathway will only be open to those 6 practices. It's just the way it works. So those 6 practices can refer out into local pharmacy, but the local pharmacist can recruit anybody for as long as they're registered with any Newham GP into the project.
Have you spoken to the 6 practices, Rachel? Has anyone spoken to them?
Not yet, no, but that comms is going out today, and then we'll be going into the practices over the coming weeks to make sure that that part of the service has more kind of data protection issues around it. So there are some delays in setting that part of the pathway up, so that the referrals from general practice into the service, there might be a bit of a delay before that's actually fully kind of set up. But the pharmacists themselves can start to recruit patients from next week. So as GPs in Newham, you might start seeing the consultations coming back from community pharmacy to you, just saying that, you know, the patient has taken part in this service and this is what we've done with them, and we think that they might be eligible for MART, or we've checked their adherence, etc.
Okay, all right, okay. Any questions for Rachel? That's fine, thanks, Rachel. I think you just need to probably have some communication with those practices, because it seems like they're not maybe aware. Aparna, maybe they need to be aware and buy into it, really, because if they're going to start getting letters asking them to review patients after they've been reviewed, then they may just be a bit kind of confused. Aparna?
Thanks, Nadeem. So, Rachel, we're doing a lot of work within our practices with regards to keeping in line with the formulary the medicines optimization scheme. So are our community pharmacies aware of the inhalers or the brands that we're being suggested to prescribe? Because what we don't want is, we don't want the pharmacists to be speaking to the patient to say, oh, I recommend you have this inhaler, but it's not something in keeping with what our local and current guidance is.
So it is according to local guidance, but also just to say that the vast majority of the communication that's going to come back to the practice is going to be highlighting where there are potentially concerns. So, for example, I've seen this patient and they're just using salbutamol and they have not been using their ICS. So today what I have done is I've reinforced the importance of them using their ICS inhaler, and it's just to communicate that back to the practice. There's going to be very, very few where there's going to be a specific suggestion, and the only one that we're specifically suggesting is that they could be switched to MART, but not a specific inhaler, just that they could be switched to a MART regime only where it might be appropriate. And obviously the assessment of whether or not they are appropriate in the prescribing will come back to the GP anyway, but it's just a suggestion that it could be something that could be used in that particular patient. And all of the practices, those 6 practices, the comms that is going out, it will also suggest if you want to have specific training from our, what's her name, her title, she's called Laura King, who's a really excellent paediatric asthma nurse. She can come out and actually do training on MART. She's the one who did the training webinar with me, and she's happy to come out and do training on, you know, on who to safely prescribe MART to and how to safely switch people onto MART regimes if practices want to take part and want to have that training.
Thank you. That sounds great.
Yeah, might be worth just speaking to the practices really, because it's part of a project that, you know, I'm at Market Street and I wasn't aware of this project, and there is potential workload coming back, and also we need to be aware of what the practice is part of really. She was just asking about, can any GP refer, is it just a pilot practices? It sounds like just a pilot practices, although they seem to be unaware of the
it's
project.
Because, sorry Nadeem, it's just because the project has only just started and we're not yet actually set up and the referral pathways are not in place, and it was very difficult right up until the last minute. I don't know if anybody's tried to put a project together like this before, but there's a lot of different things that need to happen in order for the service to get up off the ground, and the last thing we want to do is to tell people it's happening when it's not happening. So I appreciate it does feel like this is the first you've heard of it, but all of these things will be coming, and there will be clear communication to the practices in due course.
Tammy?
No, it's just a clarification, Rachel. So what we're saying is that the community pharmacists are going to be running this pilot. So any practice in Newham might get that information back. But then specifically, there are 6 practices across Newham who you will then be asking us to pilot actively referring people into the program.
That's right.
And that's it. Yeah. Okay.
That's
fine.
it.
Okay. Brilliant. Thank you.
Okay, well that's fine. That clarifies it for me as well. Okay, thank you for that, Rachel. Yeah, so we look forward to kind of more comms and communication. Sabir, are you taking this forward from the trading hub and Sule? Okay, and then we can link them into the clinical pharmacists in our practices as well. Okay, thank you very much for that, Rachel. Look forward to more information.
Thank you. Bye.
Thank you. Next is Ashley, who's going to talk to us about some local pathways from the council. Hi, Ashley.
Hi, thanks everyone for having me today. I won't take up too much of your time. My name's Ashley. I'm the strategic lead for maternity and early years within the public health team at Newham. And one of the areas that I've been working on is how we can better support refugee and asylum seekers living in our contingency hotels in Newham. And I'm here today to kind of talk to you about some referral pathways that we've co-produced with partners across the borough. They were originally designed to support partners going into these hotels and working with refugee and asylum seekers, but they've now kind of taken off and gone elsewhere, and we've found that partners from across the system have found them quite helpful if they're working with children and young families more broadly and more generally. So I was going to show some PDF versions, but it looks like somebody's put them into some slides for me. So I'm more than happy to go through on the slides, or okay, I'm going to take that as maybe I can just quickly share my screen.
Yeah, we haven't got them up, Ashley, so go ahead.
Okay, thank you. Why are they not showing up on my... Okay, so this is really just to kind of alert you to the fact that these pathways now exist and that you might find them helpful both for yourself or to put up on a staff notice board for people to be able to look over and just double check and reflect that you're really clear on the roles and responsibilities of different partners that work with young families, but also the pathways in and out of each of these partners and across to another partner. So this one here is a pathway that summarises the maternity ACORN team's referral processes, roles and responsibilities. So this team supports vulnerable cohorts within Newham. And as you can see, it just kind of talks about the different processes to take if you do need to refer a family into the ACORN team, and then what happens once they are referred, what type of support do they receive, what happens if additional concerns are raised, what happens throughout the entire journey from a woman being connected into the ACORN team right through to giving birth and then finally discharged from hospital. And as I mentioned, some of these pathways also show connections to other service areas. So once the woman gives birth, for example, what does this mean in terms of a family then being connected to a health visitor? So if I just move on to the health visitor pathway, so again, it kind of summarizes the key roles and responsibilities of the health visiting teams. There were some frequently asked questions that kept coming up when we co-produced these pathways, particularly with professionals. So things about what happens if a person misses their appointment, what happens if a family moves out of the borough. And then we've also, again, got the pathway to summarise how do you connect a family into the health visiting team, what are the contact details to do so, and then what's the process that's followed by the 0 to 19 Children's Health Service to ensure that the family's then getting one of these 3 offers of support mentioned here in the red boxes. We've also got a pathway for the MASH, so the Multi-Agency Safeguarding Hub. Again, it just explains these are the key details. This is how you make a referral. And we also found during the co-production process that partners were sometimes confused as to what does actually MASH do and where can MASH refer to. So this summarises the key partners that MASH works with. We also have some case studies in each of these pathways. These are anonymised case studies, but they are based upon real life examples that partners have brought to us and said, we don't know the answer to this question. What is the answer? And we've done that for all of these pathways. We've also got a pathway for children's centres. Again, explaining what the universal offer of support is when a family can register with a children's centre, and then what the targeted types of support that is available should a family need it. We've kind of summarised the key areas in the borough where children's centres exist. And again, we have a couple of case studies here too. And then we've got 3 other pathways for our voluntary sector partners. So some of you might be familiar with Newham Nurture. We also have a pathway for Sister Circle, which is linked into the Maternity Mates programme. And then we've also got a pathway for the Magpie project as well. And again, it follows the same type of process, how to refer, what that journey for that family is going to look like and the type of support that's available to them, plus some additional case studies on the final page. So I really just wanted to draw these to your attention, and I'm hoping that someone on this call will be able to send them out to you so that you can use yourself, or as I said, we've had a couple of hospitals and a couple of speech and language therapists actually say that they're planning to put them up on their staff notice boards or on windows for people to be able to review in their own time and at their own leisure. Are there any questions?
Thanks for that, Ashley. Anything for Ashley? Anil.
Hi, Ashley. Just wondering, in terms of safeguarding, do we have like a register at all within the borough? Because it's something that we've been asking for as GPs. We've got lots of patients that join us that are on the safeguarding register from other boroughs or other areas, and also sometimes within our own borough, but yet nobody really knows about them. When I always send off to MASH just write back and say, we don't know about this case. And then I'm trying to look for a social worker. Then I send it to a random social worker in the hope that she'll put it to somewhere. Then she replies back and says, actually, it's not my caseload, so I don't have any contact. But do we have like a central register within a safeguarding team somewhere? Because this is a real concern and worry. And your pathways are great, but actually we've got so many patients that we've got where we don't know anything about them.
I don't know the answer to that. I'm not from the safeguarding team, but I can, if you want to send me an email, I'll put my email in the chat. Just provide me with kind of a high level summary of what your ask is, and I'll then send that through to some of my contacts in the council who do work for the safeguarding team, and we can follow that up for you. And also just from a pathways perspective, that would be interesting for us to see if there's things that maybe we haven't considered, because it seems that clearly there's a big disconnect somewhere along there that we might need to be looking at further. So very happy to follow that up for you.
Lovely, thank you.
And
is
just
there like a website actually where all these pathways exist, or that we can get hold of? Because it's quite hard.
There is. I'll put some links in the chat before I disappear from this call. And just one other thing I wanted to say is that these pathways have been stress tested. So we did, all of the partners who co-produced these with us actually then went away and used them with real life case examples, and we had to tweak and change for, I mean, this has probably taken us maybe 10 months to finally put together and get sign off for. So there's been quite a lot of work that's going into actually testing these in practice. So
have they been stress tested in primary care, or from a primary care perspective?
No, and if you'd love to stress test them for us, again, please email me and provide your feedback. We can always change and update these pathways as more information comes to light. We were also in discussions with a few people from within primary care about, do we need to do a similar type of pathway to support an understanding of GP registrations and getting families connected into primary care, etc. It's not something I have the capacity to lead on, but I'd be very happy to support and bring in learnings from the pathways that I've just developed.
And also just a question about health visitors. So we often struggle with getting hold of health visitors. I think that's historical and it's only getting worse. So when we have, I think Sheeta's mentioned getting information for patients who out of borough, it can fall between MASH and health visitors. So pathways are fine, but what about the gaps in between, and just the general problem with us trying to get health visitors into our meetings and information around safeguarding that we all kind of struggle with?
So again, look at these pathways, and if you think that there's gaps or things that we could do to enhance that and maybe fix some of these problems that you're experiencing, let me know. It might not be something that I'm able to take away and do, but I can definitely connect you into the right people to have those discussions.
Okay, all right.
Thanks very much. I'll put some information into the chat before I leave.
No worries. Thank you very much, Ashley.
And just for information, we'll make sure that the various pathways are part of the newsletter so that people can just see it that way.
That's fine, Karen. I'm just trying to work out how we utilise them, because there's a lot of information and often it can be a bit of overload with that many pathways. Any ideas, Sule, how we can utilise these pathways, or where they should sit? Is it social prescribers or is it just good practices? I'm not quite sure.
I'm not sure. Nadeem, Ashley, what would you think?
We've had a few different partners do different things. So as I said, the hospitals have said that there were specific pathways that they wanted to print off and put up everywhere for staff to be able to see. We've had other partners who have asked me to come in and actually do some training and go into the pathways in a little bit more detail. I believe I am booked in to speak to the social prescribers, actually. And they are primarily at the moment being used by our family navigators and voluntary sector partners who are going into hotels or into settings where refugee and asylum seekers are currently living, so that they can be super clear on which partner they'd need to refer.
Maybe social prescribers and care coordinators often deal with the kind of the MDT aspect in children, might be helpful, actually. So maybe we can take that forward.
I think also some of the pathways, so the Children's Centre one, for example, we've had some people giving that out to families, because it really does give a useful summary as to what they can expect if they were to register with a children's centre.
Okay. All right. Thank you very much, Ashley. We'll take that forward. Thank you. Sule and Paul, you're going to talk to us about supervision and appraisal training, particularly for our staff. I'll hand over to you.
Thank you. Just a very quick reminder, really. As you know, we had a number of conversations in relation to how to support our ARRS staff and their retention. This was one of the opportunities that we have created in terms of being able to train our ARRS staff and others within the practices so that they could actually do the supervisions and appraisals for our ARRS staff in the practices. There are a number of dates and cohorts, and these programs are actually commissioned via our commissioners, and we are supporting the program, and they have had conversations with our ARRS leads in terms of looking at specifically what is required for different roles, including physician associates, clinical pharmacists, and others. So it's just a reminder, really, this is available, and at the moment take-up is not massive from Newham, but it would be really good to actually have the support from the PCNs and practices for their staff to attend these training if they're already supporting and supervising and carrying out appraisals for the ARRS staff. It's just a quick reminder, really, for everybody, Nadeem. Thank you.
Thank you. Have we got Paul on the call? Because it was anything you want to add, Paul or Sabir? Okay, if nothing for you, Sabir. So we'll just send this out, please. It's an offer for training. So thank you for that, Sule.
Yes, please, Nadeem. Thank you. And the information is on our newsletters regularly as well, if people wanted to look at the information and register.
That's fine. No, we'll send it also out with the webinar.
Lovely. Thank you very much.
Thank you, Sule.
Sorry, Nadeem, I'm not sure if Paul's here. We will just obviously make sure that CDs and PCNs are aware of it. I know the Training Hub have already shared it, but maybe in the midst of all the emails, it's not been top priority. But I think PCNs will want to take advantage of this.
Yeah, sure. And also we host a lot of the staff, so we probably need to have it offered internally at the Fed as well. Jacqueline.
Hi, sorry, this isn't related to anything today. I just wanted to ask, Nadeem, are you the one that usually chairs this GP forum meeting?
No, we normally rotate it. We normally rotate it.
Okay, so is it possible for me to have one or two of my colleagues from the memory clinic just come and maybe 10
maybe you could email
minutes?
us.
Is that?
Yeah, for the agenda items, if you could maybe email Stephanie, we'll give you the details and then we'll go from there normally. So we normally have requests for agenda items, but not during the meeting.
Brilliant. Okay, thank you. Yeah, all right, thanks.
There was a quick question, Nadeem, about the timing and recording of the training, Sule. I don't know if you...
Say that again, sorry, Karen?
There was a question. Sorry, Sule couldn't pick it up.
It's okay. Thanks, Karen. I just responded on the chat. Unfortunately, they are not recorded. But if you can tell us the times that it would be useful for, better for you to actually attend. We can talk to the provider and maybe change a couple of them to those times, if that is going to encourage more attendance.
Okay, that's fine. We can do that. Okay. Have we got Layla and Akhlasa on for COVID and flu and patient survey update? Are they on?
Hi, yeah.
Hi, Akhlasa.
Hi, everyone. Is Fabio on the call?
Okay, so it's yourself and Fabio then. Is Layla coming on as well?
No, Layla's not available today.
So Akhlasa and Fabio are primary care ICB colleagues from Newham. I'll hand over to them.
Thank you. Fabio, do you want to go first and then I'll cover the GP patient surveys? Is that all right?
Yes, I haven't prepared much slides on COVID because on the panel here there are people that know much more than me. I can see Karen smiling. They are on the field, that are doing a great job. What I can tell you, and then possibly they will go in more details, that we are going to meet the deadline of 23 October for the care homes. That has been taken care of. We also at very good pace with housebound patients at the moment, and I'm talking about COVID. The feedback I received from some of our colleagues on the field is that, unfortunately, because of the delivery of vaccines, we had the kind of missed opportunity to co-admin both flu and COVID for many patients. Nevertheless, because of their good job, we are around 50%. And this is quite encouraging compared to other areas of Nell and London. Going on the data, unfortunately, KEG was able to put something together only on Wednesday. I received some dashboard, which I've been looking at and try to work figures at. I'm not going to go through numbers because numbers, I'll tell you numbers, they will go. We are not as a place at the top. We're not at the bottom for many of the cohorts. We are doing quite well with pregnant women without any health issues, which is quite good. As expected, we are not doing that well with children between 2 and 3 years, old. Now, there is an issue there with gelatin. I've seen some of the colleagues that have pointed that out at the PM forum previously, and I'm looking into it. I just wanted to remind you that there is an alternative. Jabs are still a possibility for young children. So if you have the chance, discuss this with your patients, parents and guardians. This is something that they can do. Yes, Max. I hope I didn't say anything wrong when I see Max in the beginning.
No, you carry on.
Okay, so we know that jabs are an option for those children. I've seen some lecturers that are saying that the gelatin is very well processed. It shouldn't cause any issue because of religion beliefs, but this is a personal decision. As soon as I've got the chance to work better on the figures, unfortunately, the file I received is quite temperamental. When I try to do something, the pivot tables don't work the way I'm expecting them to work, but I will distribute some information through the practices, and then I will follow up every week. So, Bax, if you want to step in.
Yeah, Wax, the IMS lead.
Yeah, well done to everyone, really. So we've given over 20,000 flu jabs, and that kind of sits us just a little bit behind Redbridge and Havering, which is absolutely fantastic. We've never been this far ahead, so do keep going. And part of the reason is also that we've introduced a number of pharmacy sites as well. So Nell has around 200 sites. NHS Nell has 200 sites that deliver COVID and flu, which is fantastic. So well done to all primary care colleagues, and that, I say that in the wider sense. Do keep going. Do keep using your self-book or any other kind of means that you have to get patients in. But in the first 4 weeks, look, 20,000 jabs from a Newham perspective is outstanding. That's absolutely brilliant. You can do the maths among the practices, the numbers of practices, how many we're doing a week. So really, really well done. We are the highest uptake for, I think, nationally for 6 months to 4 years COVID. So thank you all for sending through your lists and looking at the dashboard. We'll keep on going with that. And many of the kids are coming for their second doses when the new vaccine, the new XB for the 6 months to 4 years will be released. Fabio's picked up the stuff around the IM injection. The team will be sending more information out about the over 65s injection and the nasal flu, around what it really means when people say they are associated with animal content and stuff like that. It is very micronized. It definitely, the nasal flu, I don't believe it to be relevant. The over 65s, it's used in the adjuvant, so that is relevant, but information will come out nice and easy for you all to read and to be able to answer frequently answered questions. With regards to the COVID, roving team, Essex Lodge, pharmacies, Wood Grange, we're all at it 7 days a week mostly. Patients should not have any issues with finding somewhere to get their jab. Predominantly is the Pfizer. The odd patient does ask for a Spikevax, a Moderna. That will be further down the line. Well done to all the teams delivering the COVID. We're doing ever so well. Again, much further ahead that we have been in previous phases. Remember, all patients have been texted centrally. They will continue to get a reminder until they come for the jab or refuse the jab, and you can do that via the text. It would be great if colleagues, when they get 5 minutes, if they could send a batch text out using the searches to those eligible or anybody really, and say, look, if you are eligible, please do attend one of the sites. It's Wood Grange, it's Essex Lodge, and roving team for the housebound. And I believe SLG will have a couple of clinics as well. We can share the details and times as well to help, but you can see the clinic times on your AccuBook in the manage organisation, manage clinic section. It's all there for you to be able to see, to direct your patients as well. People in that part of the borough prefer that site, people in that part of the borough prefer that site. So it's all going swimmingly well. The COVID vaccination program does end officially on December the 11th, I believe. We're asking for an extension. The outreach work associated with the COVID vaccination continues until the end of January and really starts to take place in the coming weeks before the early kind of walk-in rush has died down. In terms of flu, we're going to the 31st of March, as you know, that's pretty standard. But yeah, please do keep up the great work. You are doing ever so well. To be on the heels in numbers of jabs with Redbridge and Havering is absolutely fantastic. On the nasal flu again, I know deliveries came late. We need to keep pushing the 2 to 3. Use your self-book, get your supply used up, and get as many kids in. Half term tends to be a good time if you're going to direct people, but do use a self-book. Keep texting the children. They will come in. If you can't give them the nasal flu, because if that's what the parents have decided, do offer them the injection. In terms of those children who will be done at school, the schools are getting through that. That's absolutely fine. But there are children that are directed to primary care because they have medical problems, allergies, etc., and stuff like that. Be aware of that and have an injection ready or a nasal flu ready for them as well. Please don't turn them away. There will be people being redirected from schools. We do have a number of children who have medical problems. We're also started now on the 5 to 11 who are vulnerable. NHS England are quite keen to use the National GP dashboard. I'll find out more about that and I'll ping an email around next week. But we've already seen really quite good uptake from a Newham perspective in the 5 to 11. In fact, Newham is the only borough in London today and outskirts of London delivering the 5 to 11. I don't know what's happened with the other sites. And then the other thing that I was going to say was, Fabio, I did share the data pack on the WhatsApp with everybody, so they've had a chance to have a look at it. So when you send information through, it won't be fantastically new, but it gives people a direction in terms of their texting and their recall, etc., and stuff like that. And then the final thing that I was going to say is that if if you've got patients who are housebound, who haven't been jabbed, do get in touch with the roving team. There is still time. A roving team are going round and vaccinating those who are housebound. They've done ever so well. If there are people that come onto your list or raise a query, just pass their details on to the team, and I'm sure that will be actioned pretty quick, smartish. Other than that, please, staff, do come and get your jabs as well. Really, really, really important. I'm going to be doing a webinar in a couple of evenings time. In a couple of weeks time in one of the evenings. For now, we really want to get staff in. There are a lot of people out there with COVID. We don't want to pass this on to our families, friends, colleagues, etc., patients. So please do take the vaccine. You are eligible. The chance might not come round again for another year or so, if it is going to come round again. So yeah, please do take up this offer. The vaccine that's predominantly been using for staff is the XB, which is the one for the variant that's of concern and circulating right now. That's all I wanted to say, Fabio. If there was anything that I've said wrong or anything, please do update. But just again, really, really, really well done.
Okay, thanks, Wax.
If I can finish, I just wanted to say a big thank you to Wax for basically putting things in perspective much better than I would ever do. And to mirror what Wax said, thank you to everyone. It's challenging times. You're doing a great job. And thank you to Wax. It's an inspiration, I have to say. So big thanks.
Yeah, thanks, Wax, for all your kind of efforts locally, and you also the NIL IMS lead. So great work you're doing, and the figures seem really good. Anything in the chat bar, Karen? And I think there's some people coming down to your practice, Wax, at 2:30. So
yeah, you come. We've got the
sorry,
COVID,
people that are planning to
come.
come for their jabs.
Yeah, please do.
no worries. Thank you, Wax. Thanks, Fabio and Nicholas.
I still need to cover my one. I thought flu would be quick, but anyway, I won't take too long. So hopefully, everyone would have seen the presentation. If not, then we'll get that circulated. The results for the GP patient survey is out, and we can go to the next slide. Sorry. Background: this has been going on for a number of years. All GP practices know this. If we go to the next slide. So this presentation is a high-level summary of the GPPS, specifically focused on areas around access to support the capacity access plan and so on. So we've highlighted a few of the areas only, but obviously you can pull off the full report from the website. The documents are massive. The spreadsheets are even larger. Overall experience as a whole across NEL has gone down. If you go to the next slide, the next slide will kind of highlight our PCNs within Newham, so you can have a close look at those. I won't go through all of them. If you skip towards the last couple of slides, a few more. One more, please. Sorry, one more. Next steps. Yeah, so in terms of next steps, what we're going to do is obviously identify some of the key areas of improvements, work with the PCNCDs in terms of how we can work. Oh, I'm getting echo. My voice does not sound good, but anyway, so identify areas of improvements, work with you guys. Aisha, Soma, they'll be in touch with you with regards to setting up a meeting with you, touching base, not just around the GPPS, but overall the other areas are identified around the caps. So we'll be working with you, trying to support you. As I mentioned, in terms of the excuse me, in terms of the reports, you can download this directly from the website. It'll be really difficult for us to actually send any of the documents because they're so large via email. And just to also let you know, I've been told that NHS England are putting together an ICS and practice level dashboard to use for GPPS and GPAD, which looks quite useful. This will be, I believe, this this is going to be shared next week. So once we get that, we can share that with you as well. Happy to take any questions.
So are you going to be going to practices with these patient surveys or PCN CDs, or where are you taking this further?
So we'll be talking to PCN CDs just to go over in relation to the CAP plans. I believe the CAP plans are related to the last year's GPPS, so we just wanted to see what we're doing, if we need to tweak the plans maybe.
Okay, thanks for that. Wax, do you want to make it quite brief, please?
Yeah, so basically, just a quick reminder, thanks, Aklis, just for your ARRS. We're pretty clear now that there won't be any kind of addition to the deadline or extension. Get your ARRS plans, etc. In. Make sure you use that money. Otherwise, this time around, it will disappear into a black hole. There is no such thing as an accrual. Have it ready for the end of February if you have to, but make sure you spend that money. We have, on the back of the good spending, Newham, asked for a bit more because we are so low on GP numbers and nurse numbers, and we are so reliant on our ARRS staff to deliver good service. Therefore, we need more of a budget. So we'll keep pushing that agenda, but please, 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 it will really be great if you could get all of those claims in, all of those plans in, so we make sure that we get the right kind of investment we need for the recruitment that we need for our patients in Newham. Thank you.
Okay, thanks for that. Okay, thank you for that.
There was something in the chat from Laura. I don't know if Laura wants to say about it. It was about the total triage practices and the patient survey.
Yeah. It was just like I said in the message, it might be worth noticing that total triage practices in North Central London, they noticed a reduction in their GP patient survey. So I think it's good for us to look at that, and I'm sure the NEL team will be looking at that, because there can be lots of different reasons, including like what Wax is talking about in terms of availability of GPs, nurses across different areas, but also the different ways that we're offering appointments, which we're asked to do by NHS England, a total triage. But then obviously we're also asked to perform really, really highly in the GP patient survey as well. So it's something that for us to consider, to not be too hard on ourselves.
No, I agree with that, Laura. Thanks. Okay, there's no other questions, so we'll move on. Thanks for that, Eccleston and Fabian Wax. Rima, clinical leads.
Thanks, Nadeem. Afternoon, everyone. I hope everyone's okay. So on the last GP forum, there was an ask around having an update regarding who our clinical leads are. I'm hoping some of them are on the forum today. I've asked them to join just to introduce themselves. I wonder if, Steph, are you able to bring up the table of all the leads?
Yep, bear with me.
Thank you. So just as Steph's doing that, so as an update, you may all know or remember our clinical lead for cancer, who was Helen. So unfortunately, she's stepped down for the role as she's left the borough of Newham and is working elsewhere. Obviously, that does leave a gap in that particular area, and we have some quite major kind of things around reducing our finances and the expenditure on CCPL. So we're going to have to, it's unlikely that we're going to be able to recruit into that post going forward, because we're just not going to be allowed to have that funding and resource. So Helen had sent an email to all the CDs with people that she'd been working with across North East London. And now that we have the Cancer Alliance, which is forming, that should help mitigate some of those gaps that we have. Obviously, if there's anything else, then please do email me directly. Laura, I can see you've got your hand up. Is there anything you want to say now?
Yeah, it was just a very quick one about the cancer leads. Can I presume then that the cancer leads in the other areas, the other boroughs, when their contracts finish, which I'm presuming they must be on short contracts, they won't be extended as well, or will they? Just in terms of equity, are the other areas, do they still have their cancer leads?
So they still have their cancer leads, because the contracts are up till each area will have a different length of contract. But by April, we have to present a saving of 30% on our expenditure on clinical leads. Now, for some boroughs, they may include the cancer lead within that core in others, they may not. It's just unfortunate for us because that lead has now left. It's difficult for us to then justify how we can use new resource to basically employ back into that role. Now, it's extremely challenging to make a reduction by 30% because you can imagine all the areas are extremely important in terms of priorities. However, there is significant funding for the Cancer Alliance at North East London level, and we're trying to work out how we can then use the Cancer Alliance and the budget that they have to try and use some of the clinical leads that they've employed to then distribute some of that work or to link up with PLACE. So it may be that some across the 7 boroughs decide to keep their cancer lead and chop elsewhere. But for us, we're likely to make the decision that we're not able to recruit into that post going forward now that it's vacant.
So I think what you're saying is that there'll be a similar budget for the boroughs, but there might be slight variations in terms of clinical leads in each borough. And I suppose that makes sense.
Yes, we will all have the same budget because we're all asked to reduce by 30% from a budget that's existing. But it's up to the individual boroughs to come up with what their plans are.
Yeah, the financial pressures. Okay, huge. Carry on. We'll take Laura's question at the end.
Okay, so if we look down the list, I'm hoping that most of you will know most people on this list. The gaps are for those posts that were not filled in the process back in January, and just like the cancer lead, they're not going to be recruited to. So for those, there are new, if we can just go to medical optimization, because we've got Asthma. Answer, do you want to, I don't know if you're on, do you want to just introduce yourself? Because I think because you are new to the kind of system, that'd be nice to introduce yourself.
Yeah, that's fine. Hi everyone. So I've become the new Meds Optimization Clinical Lead for Newham. I've probably spoken to quite a few of you previously with regards to any concerns you have. What I'll do is I'll put my email address in the chat box just so that anyone can note it down in case they want to contact me with regards to any concerns to do with prescribing in the borough. Would that be okay? Yeah.
Yeah, put it in the chat bar. Thanks.
Thank you. And we've got Sharika, who is our CBD lead. I'm not sure that she's on the call. She's working with some of those priorities within the CBD area. We've got Tammy, as you all know, who is our diabetes lead, and Duncan, who's remaining as our respiratory lead. And then we've got Robin, who is a learning disabilities and autism lead, who's actually works for ELF. So he's part of the LD team there and works closely with Gary, who's our LD commissioner. If we go down the list, I'm seeing if there's anyone else new that people are not aware of. No. Okay, so that's our current list. Obviously, we are re-looking at what the model is going to look like from April. I'm trying my best to try and maintain what we have currently, because we do have gaps where we have saved some money in posts that haven't been recruited to. So on the NHC website, you will have email addresses to all of these clinical leads, so specialise in those areas. If you have any questions, then please email them directly. Obviously, I'm also here if you have any particular questions. Our planned care, so if you click on the multi-borough is our planned care leads. So they're all GPs. Unfortunately, none of them are from the Newham area, but they are from Waltham Forest and Tower Hamlets. So they have. So with the planned care, they actually all individually focus on specialities. So one of them might be an MSK, some of them might be dealing with the rheumatology pathway, and it can vary. So you may not necessarily get an answer. So for planned care things, if you come to me directly, I can then signpost to which clinical need needs to be involved in those conversations.
Thanks for that. And I think some of those are in our neighbouring boroughs, aren't they? Cam's in from Forest and Leslie's in Tower Hamlets. Laura was just asking about whether we get the same funding as other boroughs, even though
we do,
because we are larger.
Well, we do, because they try to standardise it all. So historically, actually, there were other boroughs that had more funding. So it was cut down to 35 sessions for the recruitment cycle this time round. And now we're having to reduce that by 10.5 sessions. So we're only going to be having 24.5 session budget for each borough.
Okay, that's Fine. So that per capita, we're always a bit lower, and we always keep fighting for that now.
Yeah,
Right.
absolutely.
I was going to say, yeah, just on that one, so actually we were bought in line with others, weren't we, Reeves? Because our sessional rate was much more. And we were brought in line with other boroughs as well. So yeah, the sessional rate is now equal as well. Reeves, I was going to say, for your sake, really, there are planned care leads there, and I know that's like the biggest query centre forum, blah blah blah. I mean, how do we? Isn't it better for you, because you've got other stuff to do, that we go directly to these, or do you want to funnel it? I'm just thinking about your workload.
I'm happy for them to go directly, but the issue is that it's not clear on what work streams all of them are working on. So and I've been talking to Julie, because we're trying to revisit what the planned care roles, clinical leads are going forward. It's likely that we're all going to have to reduce our budget allocation for planned care as well. So we've got 3 sessions per borough. So that's Tower Hamlets, Waltham Forest and ourselves allocated. Now, I don't see the work of 3 sessions worth locally in Newham, and I've said that multiple times. So I think we're trying to revisit what actually that looks like, because when GPs aren't from your area, I don't think you necessarily get that kind of direct interaction with them. They should be on these forums, they should be presenting, what's happening in planned care, and we don't get that visibility. So I don't see that we're getting our 3 sessions worth. So it's likely we're all going to have to cut by 1 anyway, just to make up that 30% reduction. But we need to revisit what that planned care looks like. Now, Roberta is working quite hard on this with Julie, and then I'm also involved in some of those conversations. So once we have got those kind of clear plans, if I think that, yes, I understand that what each of these leads are working on, then that's fine. And then I can come back here and say, well, GPs, can you please direct your questions to these individuals based on the speciality areas that they're working on? But right now, it's a bit of a mess. So I'd prefer if I am actually just at least copied into any of the emails, because then I can at least work out what to do.
So it's kind of a work in progress.
Exactly,
so if you're not sure, contact the clinical lead and maybe copy in Rima. Tammy?
Thanks, Noom. Thanks, Rima. So what's the methodology that we're going to use to try and reduce, the sessions? Because, is it going to be aligned to our Newham priorities? If that's the case, do we have to have an honest conversation about what we can and can't do? If we haven't, like, losing Helen is a big thing. And you've just said, that we don't have any planned care leads, and we don't see the benefit of having that in Newham. That's a concern, isn't it, if we don't have a cancer lead, and the same for any other intervention. So I think, it'd be really good, and I'm talking about this with my LMC hat on. I think it's really important for us to know what are, that there's going to be a really
good question, Tammy.
A really good methodology, but I think
so the methodology, if I come back on that, Tammy, the methodology at the moment is really looking at our clinical priority areas for the borough, okay? And what we're working at is, what is our core? What is it absolutely our core of what we require in Newham based on those priorities? You could argue that cancer is part of that, but as I said, because of the Cancer Alliance, we've got to see where that budget and resource is sitting, because they've basically essentially pulled it up from boroughs and pushed it into a massive kind of Cancer Alliance. Now, if the budget's sitting there, then why can we not be using that and the clinical leads that have been recruited to the Cancer Alliance working at place level as well? Because then otherwise there's duplication in the system. But for me, the core areas and what we're working on in the partnership is around, the long-term conditions, the mental health, the CYP, and LD's quite up there as a priority as well. So it's kind of, what are our core values and priorities that we need to maintain in the partnership, and that's where I think we need to maintain our sessions. Anything we get on top of that is a bonus. Yes, we could apply, in the future and say we need a 6-month post in X, Y, and Z. We may be lucky, we may get it, but we need to work out what the core is, and that's what we're doing at the moment.
Okay, thanks for that, Rima. So that will continue those conversations locally and in deciding how to, but some of it's quite pragmatic. If you don't have people who want to sit certain roles or don't apply for certain roles, then it kind of makes sense to, if you're making cuts, not to employ there or not to go in that direction. But there's a few factors to think about. But thanks, Tammy. Okay, there's no other questions. I think we can probably.
There was just one. I don't know whether it's relevant for now, Nadine, one from Bapu about CCPL and and ask.
Yeah, probably we're going to be having these discussions about clinical leads. I think we'll probably just leave it at that, Karen. But we can take Barbara's question outside this meeting. Is that all right, Rima?
That's fine. I don't know what is the full expansion. What does that? I don't know what that means. Sorry, Bapu.
I just want to know what it stood for. CC, is it clinical commissioning place level, or what is it? What does it stand for? I mean,
clinical professional leads. Clinical. No, it's nothing to do with commissioning.
I know. With all
We're so used to saying acronym.
Yeah, it's fine with acronym, but I just want
It's just our clinical. It's a clinical and care professional leads. So it's a clinical and care because now it's health and social care together, and it's our professional leads.
But it's a discussion we're taking forward anyway. So
yeah, and it used, just to point out, it used to be just CL, just clinical leads, but now because they're all working essentially for the partnership, it's changed to clinical and care professional leadership.
Okay, thank you for that, Rima, and we'll take that forward anyway. We'll get updates from you further as we get the changes and so. All right, thank you everyone for attending, and we'll see you next month for the GP forum. Bye.
Bye. Thank you.
Thanks everyone. Bye bye.